So our next speaker will be Anita Parker from Rush, and she is going over how will the perfusion profession meet the needs of growing adult congenital heart disease with the patient population.
I brought a stool so you guys can see me. I've learned. All right. Hi, everyone. First, I would like to thank the Sanibel Symposium for inviting me to speak today. I feel honored to be here. Today, I will be speaking about the adult congenital heart disease patient population. Before I get into my talk, I would like to share what led me to this topic. Before attending perfusion school, I worked at Boston Children's Hospital. I worked there for 7 years, with my last 2 years as a perfusion assistant. One day at work, I overheard my manager was visiting a neighboring hospital to consult on an adult congenital case. I remember being fascinated by this collaboration, and I wanted to know more. What does a consultation between a peds and adult perfusionist look like? Why was it needed? What do they discuss? I was hungry for answers. It turned out the neighboring hospital was building an adult congenital program, which made me think, what happens when our PD congenital patients grow up, and who cares for them? So as pediatric medicine and surgery advances, we're able to help and treat more complex children. But that also means that we are changing history in a way, natural history in a way, which is kind of leading us into the unknown. And so I thought about this and started to ask, well, how will the perfusion profession meet the needs of the growing adult congenital heart disease patient population? So disclosures, I have nothing to disclose. So here's a brief overview of what I'll be discussing today. So to better understand the growth of the adult congenital heart disease patient population, let's briefly review the history of congenital heart disease and the surgical advancements that have been proved as CHD outcomes. There have been many surgical advancements in the CHD field, including Dr. Robert Gross, who performed the first CHD surgical repair when he performed a PDA ligation on 7-year-old Lorraine Sweeney in 1938. In 1953, Dr. John Gibbon used the heart-lung machine to repair an ASD, marking the first successful use of CPB in CHD surgery. As you can see, there have been many surgical advancements that have led us to today, including advancements in pediatric cardiology, diagnostic testing, and cardiac catheterization. The survival of those born with CHD was once 15% in 1950 and early, but due to these advancements and others, it is now greater than 90%. And it is now expected that 90% of children born with severe CHD will survive to 18 years of age. So what is the prevalence of CHD? In 2017, the estimated global prevalence of CHD was 1 to 8 cases per 100 live births, which is a 4.2% global increase since 1990. It is estimated there are 12 million people living with CHD worldwide. Additionally, the number of deaths attributed to CHD has decreased by 34.5% since 1990. As for the US, in 2010, it was estimated that CHD affected approximately 8 to 10 cases per 1,000 live births, or 1% of all births, which is around 40,000 births per year, making it the most common birth defect in the US. Furthermore, 25% of those births are considered critical or life-threatening heart defects. In 2010, it was estimated that there were 1 million children living with CHD and 1.4 million adults living with CHD. Unfortunately, our current CHD estimates are based off of CHD data from Canada, as the US lacks a long-standing CHD database. So now that we have reviewed CHD, let's discuss ACHD. So we are now at a point where there are more adults than children with CHD, and the CHD population grows by 5% yearly. So what's the big deal? Well, the big deal is this, the ACHD dilemma, which is 7, if not more, factors that feed into each other that make caring for this special patient population particularly challenging. So what are they? The first is the growing surgical complexities. The ACHD population are now living long enough to develop comorbidities and acquired heart diseases that can further that add further complexity to their cases. 2, there's a shortage of cardiothoracic surgeons. While there's already the shortage of cardiac surgeons, ACHD patients may require additional surgeries due to their previous operations or age-related illnesses. 3, there's a limited number of ACHD centers. It is reported those with ACHD have 3 to 4 times higher rates of ER visits, hospitalizations, and ICU visits. And between 2003 and 2012, there was a significant increase in simple ACHD hospitalizations and by 101%, and complex ACHD hospitalizations by 53%. All right, so I'm flying blind right now because I cannot get this to scroll, but it's okay. Oh, there it is. We found it. And I lost it. No, I found it. Keep things exciting, you guys. Okay, so also in the United States, it's estimated that 45% of ACHD populations live greater than an hour to an ACHD center, with 5.4% living greater than 4 hours away. So number 4, which is adults with ACHD have difficulty obtaining health insurance, which may lead to more ACHD patients coming in only when they are critically ill. 5, there's this misconception that surgeries are curative, not corrective or palliative. This feeds into number 6. There's this loss of patients during transition from pediatric to adult centers. It was reported that even a lapse in care of 2 or more years can increase the need for surgical or catheterization intervention within 6 months of return to cardiac care. Furthermore, in 2021, a meta-analysis and system review by the AHA, the United States had the greatest discontinuity of cardiac follow-up compared to Canada and Europe, particularly in simple CHD. And finally, 7, research can be difficult due to the heterogeneity of this group. So in 2018, the American College of Cardiology and the American Heart Association updated their 2008 guidelines for the management of adult with CHD. The new AP classification for ACHD combines both anatomical and physiological classification systems together to better capture the complexity of the ACHD anatomy and physiology. Anatomical complexity is graded 1 through 3, and the physiological stage is classified as A through D, which represents the increasing severity in the NYHA functional classification of symptomatology, hemodynamic disturbance, and end organ damage. Now, severity of ACHD is based on native anatomy, surgical repair, and current physiology, which can help with surgical planning. So long-term complications and comorbidities. Adults with CHD must deal with residual and sequelae related to their CHD, as well as acquired comorbidities as they age. Here's an extensive list of some of these, including heart failure, which is a leading cause of death in adults with CHD. Also, there's a study in 2022 which looked at the incidence and outcomes of aortic dissection and rupture in ACHD in Texas from 2009 to 2019 and found that ACHD does confer an added risk. So one of the challenges of studying this population is the lack of long-term data. I want to share a study with you published this year, which assessed if patients with simple CHD faced an increased lifetime risk of comorbidities and mortality compared to matched controls without CHD. Using the nationwide Danish registry from 1977 to 2018, the researchers include subjects at 5 years of age and followed them until age 90 or age in December of 2018. What they found was that patients with simple CHD had shorter life expectancy, along with excess lifetime risk for comorbidities compared to their matched controls, particularly in neurological disease, pulmonary disease, heart failure, and stroke. Here is another study published just this year. The study used data from the Swedish National Inpatient, Outpatient, and Cause of Death Register between 1950 to 1999 and tracked those that survived to age 18 years of age until death or at end of the study in 2017 and matched them to controls to assess mortality and morbidity in ACHD. What the researchers found was that mortality was 3.2 times higher among ACHD patients compared to matched controls, but at the 50-year follow-up, more than 75% of the patients with ACHD were still alive. They were living past middle age and into the 60s. All right, so what is the current research of ACHD and CPB? After looking through what I felt like was hundreds of articles, these are the only 2 articles I could find that were specifically about ACHD and CPB. The top article, which is over 17 years old. The second article by Martins et al. Found that LV dysfunction was associated with prolonged CPB time and that obesity was a protective factor. Still, there lacks current literature and highlights the need for more research regarding ACHD and CPB. So what are some of the latest research in ACHD? So let's look at the top left article first. It is reported that 10% of adults with moderate complex CHD are in care at an accredited ACHD center. And between 2006 and 2012, the number of ACHD patients that presented to the ED increased by 41% for simple and 38% for complex. Additionally, 30% of those patients presented to smaller or medium EDs due to proximity, which are often not sites specialized in ACHD. What was most shocking to learn is there is no requirement for general or pediatric emergency medicine providers or adult critical care clinicians to demonstrate competency in ACHD care. This article addresses this problem by developing a novel simulation training to teach ACHD emergency medicine to help train the gap in ACHD ED management. The second article at the bottom left examined the use of transfusion in ACHD patients undergoing cardiac surgery and found that, yes, ACHD patients that received blood products experienced more complications and worse in-hospital outcomes. The third article was interesting and discussed how 3D printing holograms and AI can be used to help with ACHD care. If you check out the article, they have some really cool pictures of a 3D modeled single ventricle and how they use that to determine placement of a VAD. For legal reasons, I couldn't post it, otherwise I would have. So when I first started my research into this field last fall, most of the literature discussed how ACHD patients do not receive mechanical circulatory support due to the patient-specific unique anatomical features and multiple surgeries, etc. However, recent studies are now showing that VADs can be used in ACHD patients and how they can help them, such as end-stage heart failure. Just last week, I saw this article published by the Mayo Clinic about their first Epstein patient to receive a VAD as a bridge for transplantation. One last thing I'd like to discuss is the combined heart and liver transplant. It is estimated that 70,000 patients worldwide have undergone a Fontan procedure. However, as these patients age, there's the failing Fontan that is associated with liver disease. The top article, which was published last month, assessed the incidence and outcome of ACHD patients undergoing combined heart and liver transplantation and compared them to those undergoing isolated heart transplantation. Using data from the Organ Procurement and Transplantation Network database between 2000 and 2020, what they found was there was no difference in hazard of 1-year mortality for patients undergoing combined heart and liver compared to just heart, which is very interesting, especially since they reported the number of adults undergoing combined heart and liver will continue to increase. So today I want to present information about the growing ACHD population along with some current studies in the developing field. There is still a lot unknown about the future of this population, which necessitates the need for additional research. Additionally, it remains unknown how this patient population will impact the perfusion field. Will we see a need to develop ACHD training at rural hospitals as the number increases? What about ACHD in pregnancy? So as I start my second year of perfusion school and begin my research project, I hope to help identify some of those potential challenges that may affect the perfusionist. Additionally, I hope to identify some of the trends in ACHD by collecting data from the past 10 to 15 years from the STS CHD database with a focus on CPB. This is a growing population, and it may take a while to see the impact this population will have on this field. But I think with continued involvement in current research, through collaboration, we can help to provide this special patient population with the best care. I leave you with this quote: "Alone we can do so little, together we can do so much." Thank you. I now welcome any questions.